Welcome to Prepare Tennessee LTC, a podcast created to provide resources and information on the current topics experienced within Tennessee long-term care and skilled nursing communities. I'm your host, Rachel Turner, an Associate Program Manager here at Vanderbilt University Medical Center's Program in Disaster Research and Training. Today, I'm here with Dr. Michael Freeman and Dr. John Walsh, two co-directors of Vanderbilt University Medical Center's Program in Disaster Research and Training. Please join me in listening to their presentation on the CMS Final Rule. You are currently listening to Part 2 in this 4-part series.
Module M101B is the second of 4-part series explaining the CMS Final Rule requirement standards for long-term care and skilled nursing facilities. In this module, we will cover sections E-0022, which identifies available resources for sustaining healthcare and life safety. Section E-0023 addresses maintaining residents' medical records and medical information. Section E-0024 discusses the establishment of policies and procedures for utilizing volunteers. Section 0025 covers relocating residents and maintaining continuity of services. And the last section, which is E-0026, addresses the facility role for caring for residents at alternative care sites. Section E-0022 covers available resources for sustaining healthcare and life safety. Full evacuation of a facility is both an expensive and complex undertaking. Many times the better option is to shelter in place. This requires comprehensive planning addressing available resources such as food, medical supplies, power sources, water, other essential items for sustaining healthcare and life safety, the ability to maintain adequate staffing, and the accessibility to lines of communication. How long a facility can endure and maintain adequate services for its residents, staff, visitors, and others in the facility has a direct bearing on determining whether evacuation or sheltering in place is the better alternative. There are many factors to consider when making these types of decisions, so getting as much input from a number of your operating personnel is helpful in preparing for such an event.
Survey procedures for E-0022. Verify the emergency plan includes policies and procedures for how it will provide a means to shelter in place for patients, staff, and volunteers who remain in a facility. Review the policies and procedures for sheltering in place and evaluate if they align with the facility's emergency plan and risk assessment. E-0023, maintaining residents' medical records and medical information. The facility emergency plan must include policies and procedures that establish a system of documentation for maintaining residents' medical records and medical information in a secure manner while protecting confidentiality of this information. Resident medical records and information must be readily available to supporting continuity of care during an emergency. Regulations and laws protecting an individual's personal health information are covered under the Health Insurance Portability and Accountability Act, otherwise known as HIPAA, and the Privacy and Security Rules at 45 CFR Parts 160 and 164. It is recommended that all staff be familiar with HIPAA and applicable sections of the privacy and security rules. Confusion at times occurs when staff attempts to interpret these provisions, so it is advisable that specific policies and procedures be established to minimize misinterpretation and usage, not only during emergencies, but during normal operations.
Survey procedures for section E-0023. Surveyors may ask to see a copy of your policies and procedures that documents the medical record documentation system your facility has developed to preserve resident information, protect confidentiality of resident information, and secures and maintain availability of records. Section E-0024 is the establishment of policies and procedures for utilizing volunteers. Often during an emergency or disaster, surge issues require the use of outside medical and non-medical volunteers to offset staffing needs. The use of medical volunteers requires proper certification and licensing issues for facilities to include the establishment of a process for integrating healthcare professionals into your system of operations. Healthcare professionals must only perform services within their scope of practice and training. Some facilities may require privileging and credentialing processes for professionals before they are allowed to volunteer. How the facility wishes to use its volunteers is up to them, so long as applicable state laws, scope of practice, and facility policies are followed. At minimum, each facility must have established policies and procedures in its emergency preparedness plan addressing the use and practice of both healthcare professionals and non-medical volunteers. Some volunteer examples include non-governmental organizations, faith-based organizations, the National Disaster Medical System members, Medical Reserve Corps members, and the state-based volunteer registries such as Emergency System for the Advanced Registration of Volunteer Health Professionals.
The plan should include processes for contacting volunteers and off-duty staff. Consideration should also be given for establishing collaborative agreements among other nursing facilities or organizations for acquiring available healthcare personnel. A number of contingencies for anticipated staff shortages should be considered and planned for. Each HCC works with a cadre of medical, behavioral health, and other volunteers that can be utilized during an emergency. Survey procedures for 𝐒𝐲𝐧𝐬𝐬𝐢𝐬. Verify the facility has included policies and procedures for use of volunteers and other staffing strategies in its emergency plan. 𝐒𝐲𝐧𝐬𝐬𝐢𝐬. Relocating residents and maintaining continuity of services. In the event your facility is required to relocate residents during an emergency or there is a cessation of operation, policies and procedures must address what arrangements exist with other facilities for maintaining continuity of resident services. These prearranged transfer agreements should include 1. Formal contractual agreements spelling out the responsibilities of both the transferring and receiving facility. 2. Services to be provided for maintaining resident care. 3. Staffing and equipment requirements. 4. Reimbursement. 5. Transportation needs between facilities.
Collaborating with your regional healthcare coalitions, emergency management agencies, and other response agencies within your community and surrounding areas can assist in assessing and determining the level of resources available to your facility. Other facilities in your region may be able to provide examples of applicable memorandums of understanding, MOUs, and transfer agreements for use by your facility. It is always recommended that all legal documents be reviewed by your facility's legal counsel. Surveyors may ask to see copies of the arrangements and/or agreements the facility has with other facilities to receive patients in the event the facility is not able to care for them during an emergency. Surveyors may also ask facility leadership to explain the arrangements in place for transportation of residents in the event of an evacuation. Section 𝐒0026 addresses the facility role for caring for residents at alternative care sites. An emergency or disaster may require emergency management officials to open alternative care sites due to the severity of events. Facilities are required to develop and implement specific policies and procedures outlining their role for caring for residents at these sites. This is a collaborative effort between facilities and state and local emergency management officials in order to plan for contingencies in continuing to provide care services to residents, even when those services have been severely disrupted at their facilities. Appendix Z, Section 𝐒0026 states, a facility's policies and procedures must specifically address the facility's role in emergencies where the President declares a major disaster or emergency under the Stafford Act or an emergency under the National Emergencies Act, and the Health and Human Services Secretary declares a public health emergency.
1135 waivers. Section 1135 waivers refer to the ability of the Department of Health and Human Services Secretary to issue temporary suspension of certain federal requirements. Examples include licensure requirements, physician self-referrals, payments for out-of-network providers, sanctions under the Emergency Medical Treatment and Active Labor Act, conditions of participation, or other certification requirements, sanctions arising from noncompliance with HIPAA privacy regulations. The facility must have policies and procedures in place for dealing with potential 1135 waivers. In certain cases, other Social Security Act provisions and CMS regulations can provide flexibility to providers during an emergency. One other requirement that should be noted is that policies and procedures should also address emergency situations where a declaration is not made and a 1135 waiver is not warranted. Disasters affecting a single facility would fall under this category. Regulations relative to Section 1135 waivers can be somewhat complex when interpreting waiver authority in national emergencies. So it is advisable to become thoroughly familiar with all its provisions and how the law is applied. References and information sources can be found on the VUMC Emergency LTC website. Survey procedures for 𝐒𝐲𝐧𝐨𝐬𝐢. Verify the facility has included policies and procedures in its emergency plan describing the facility's role in providing care and treatment, except for RNHCI for care only, at an alternative care site under an 1135 waiver.
If you have questions regarding anything that was mentioned in today's podcast or would like to learn more, please visit our website at www.emergencyltc.org.